Hi, in this video we will talk about celiac disease. I'm going to read it from Nelson's edition 22, chapter number 384, page number 2327. Let's start. Etiology and epidemiology. Celiac disease is an immune-mediated systemic disorder. Fine, it is an immune-mediated and systemic disorder which is elicited by gluten, which is present in the wheat and related prolamins from the rye and barley in genetically susceptible individual, and is characterized by the presence of a variable combination of gluten dependent clinical manifestation. CD specific antibodies, human leukocyte antigen HLA-DQ2 or DQ8 haplotypes, and enteropathy. CD specific antibodies comprise autoantibodies against the tissue transglutaminase TG2, including the endomycin antibodies, and antibodies against forms of the demyelinated gliadin peptides DGPs. Moving ahead, celiac disease is a common disorder with 1.4% global prevalence of positive serologies and 0.7% of the biopsy proven disease, with variability across the countries. Crohn's celiac disease affects both the children and adults, second to third decade of the life in adults. Although celiac disease develops in genetically susceptible individual, environmental factors might affect the risk of developing the celiac disease or the timing of presentation. Neither breastfeeding during the gluten introduction nor any breastfeeding has been shown to reduce the risk of celiac disease. The impact of early gluten introduction, age 4 months, on the risk of developing celiac disease is contradictory. Large amounts of gluten at young age, at 6 months, may convey the risk of earlier development of the celiac disease, autoimmunity, the positive serology, and the celiac disease, whereas lower amounts of the gluten in the first 2 years of the life may convey lower risk of the celiac disease. Okay, so if large amounts of gluten are increased at a younger age, it increases the risk of earlier development of the celiac disease autoimmunity, but if in lower amounts then in the first 2 years of life, then it lowers the risk of celiac disease. Infectious agents may have been hypothesized to play a causative role, as frequent rotavirus infection was shown to be associated with increased risk of developing celiac disease. So this is something new, that infectious agent, which one? Frequent rotavirus infection was shown with the increased risk of developing celiac disease. It is plausible that the contact with the gliadin at the time when there is an ongoing intestinal inflammation alters the intestinal permeability and enhance antigen presentation can increase the risk of developing celiac disease, at least in a subset of persons. The mode of delivery, socioeconomic status, season of the birth, and the use of drugs have been associated with the risk of celiac disease, but the evidence is contradictory. Now let's talk about the genetics and pathogenesis. A genetic predisposition is suggested by family aggregation and concordance in the monozygotic twins, which approaches 100%. The strongest association is with the HLA-DQ 2.5, 1 or 2 copies encoded by DQ-A105 for the alpha and DQ-B102 genes for the beta chain. So the strongest association is with what? Strongest association is with the HLA-DQ 2.5. Such a DQ molecule has been found to be present in more than 90% of the Crohn's celiac disease patients. The highly homologous DQ 2.2 molecule confers a much lower risk, whereas the data available on the DQ2 negative CD patients indicate that they almost invariably are HLA-DQ8 positive. A gene dosage effect has been provided in the prospective studies, and a molecular hypothesis for such phenomena has been proposed based on the impact of the number and the quality of the HLA-DQ2 molecules on the gluten peptide presentation to T cells. The HLA locus is most significant and dominant gene associated with the celiac disease. However, other loci known to contribute to the celiac disease have been documented. Most types have been found to be associated with other autoimmune disease such as the type 1 diabetes. Fine. So the celiac disease have been found to be associated with other autoimmune diseases like the type 1 diabetes. Interestingly, very few polymorphisms Associated with the celiac disease are in the coding regions, as they often are in the binding sites for the transcription factors, where they then affect the gene expression. Celiac disease is a T cell mediated chronic inflammatory disorder with an autoimmune component. This is an important line, that it is a T cell mediated chronic inflammatory disorder with an autoimmune component. Altered processing by the intraluminal enzymes, changes in the intestinal permeability, and activation of the innate immunity mechanism precede the activation of the adaptive immune response. Immunodominant epitopes. One second. So this celiac disease, no, it is at first is T cell mediated, a chronic inflammatory disorder which has an autoimmune component to it. Altered processing by the intraluminal enzymes, changes in the intestinal permeability, and activation of the innate immune mechanism precede the activation of adaptive immune response. So these all things, they precede the activation of adaptive immune response. Before this activation of immune response, no, there are these things occur. Immunodominant epitopes from gliadin are highly resistant to intraluminal and mucosal digestion. Immunodominant epitopes from the gliadin are highly resistant to intraluminal and mucosal digestion. Fine. Incomplete degradation favors the immunostimulatory and toxic effects of these sequences. Wait, I'll explain all this. Let's just read it through, then I'll explain it. Let's read from here. Altered processing by the intraluminal enzymes, changes in the intestinal permeability, and activation of the innate immunity mechanism precede the activation of adaptive immune response. Immunodominant epitopes from the gliadin are highly resistant to the intraluminal and mucosal digestion. Gliadin, where is it coming from? It is coming from the gluten. Fine. And this gliadin is kind of highly resistant to the intraluminal and mucosal digestion. So incomplete degradation favors the immunostimulatory and toxic effects of these sequences. Some gliadin peptides activate the innate immunity. In particular, they induce the interleukin 15. So this gliadin is inducing what? This gliadin is peptides activate the innate immunity, particularly which one? Interleukin 15. The later, but also type 1 interferons may alter the tolerogenic phenotype of the dendritic cells, resulting in the lamina propria T cell activation by the other peptides presented in the context of HLA-DQ2 or HLA-DQ8 molecules. And this gliadin specific T cell response are enhanced by action of TG2. The enzyme converts the particular glutamine residues into the glutamic acid, which results in the higher affinity of this gliadin peptides for HLA-DQ2 or DQ8. So the glutamine residues, they have there is a higher affinity of this gliadin peptides to these HLA-DQ2 and DQ8, and the patterns of cytokine produced following the gliadin activation is dominated by the interferon gamma. Let's just understand whatever we have read till now. From this interferon gamma, we will read again. So what is happening here in the last paragraph? Celiac disease is a chronic inflammatory disease of the small intestine, right? That is mainly mediated by T cells and has an autoimmune component. And it occurs genetically in genetically susceptible individual after they consume this gluten, which is present in this barley, wheat or rye. Let me write it somewhere. And the harmful part of the gluten is called as the gliadin. So from gluten, what is coming? Gliadin is coming. Okay. Normally, digestive enzymes break down the proteins completely. However, gliadin is resistant to complete digestion. This molecule is resistant to complete digestion. So, large gliadin peptides remain in the small intestine. Fine. These large molecules, large gliadin peptides, they remain in the small intestine. In people with celiac disease, the intestine lining also becomes more permeable allowing these gliadin peptides to cross the lamina propria beneath the intestinal epithelium. So now these molecules, they cross the lamina propria. They cross this lamina propria. Fine. And they come beneath the epithelium, and the immune response begins with the activation of immune system. Fine. Now the immune system is activated. After they crossing, they activate the immune system. Okay, after the immune system is activated, this gliadin peptides stimulate the intestinal epithelial cells. They are stimulating this epithelial cells to do what? To release the interleukin 15. Now interleukin 15 is released, okay, from the intestinal epithelial cells, and this activates the intraepithelial lymphocytes, which start damaging the intestinal epithelial cells. What is happening? This interleukin 15, no, it is activating what? Intraepithelial lymphocytes. Okay, this intraepithelial lymphocytes, now they act on the epithelial cells only. They act on the epithelial cells, intestinal epithelial cells. And they start damaging the intestinal epithelial cells. Next, the adaptive immunity is activated. Okay, in the lamina propria, the enzyme tissue transglutaminases modify the gliadin by deamidation. So in lamina propria, there is an enzyme present, that is tissue transglutaminase. This modified gliadin, so it does what? Tissue transglutaminase does what? It modifies the gliadin. Now this modified gliadin is presented by the HLA DQ2 and DQ8. And it is presented this is presented by this HLA-DQ2 and HLA-DQ8 molecules on the antigen presenting cell. These are presented to whom? To CD4 positive T helper cells. Presented to CD4 positive T helper cells. This activates the T cells, which release the inflammatory cytokines and such as the interferon gamma, leading to chronic inflammation and destruction of the intestinal villi. So these helper cells are doing what? They activate the T cells, we all know. And this is leading to what? Release of cytokines. So the cytokines are released, and with cytokines like interferon gamma, and this cytokine release is finally leading to what? Finally, there is chronic inflammation and destruction of the intestinal villi. Fine, this is the chronic inflammation and destruction of intestinal villi is caused. At the same time, B cells are stimulated to produce antibodies, which include the antibodies like anti-tissue transglutaminase antibody and anti-endomysial antibodies. Fine, and the combined effect is there is villus atrophy, there is crypt hyperplasia, and there is increased epithelial lymphocytes resulting in malabsorption, which causes symptoms such as the chronic diarrhea and weight loss and poor growth. Okay. So what is the combined effect that I just told you? It was causing the villus atrophy, the crypt hyperplasia, and increased intraepithelial lymphocytes, which is causing malabsorption, and symptoms appear like chronic diarrhea and weight loss and poor growth. Okay, let's get back to where we were. We have to start from here. It was not that hard, right? So in simple terms, what happened was gluten is broken down into gliadin, and gliadin triggers the innate immune system, which then adaptive and then adaptive immune system is also triggered in genetically susceptible individuals, leading to immune mediated damage of the intestinal villi and finally leading to malabsorption. Okay, let's read from here. We'll first read and then we'll try to understand. The pattern of cytokine produced following the gliadin activation is dominated by the interferon gamma, T helper type 1 skewed, interleukin 21 is also upregulated. In the downstream, T cell activation, a complex remodeling of the mucosa takes place involving increased levels of the metalloproteins and growth factors. There is T cell activation of a complex remodeling of the mucosa takes place. What is happening? Remodeling of mucosa is taking place, which is involving what? Increased levels of metalloproteinases and growth factors, which lead to classical histological finding of this is leading to the flat mucosa. Okay. A severe impairment of the intraepithelial lymphocyte homeostasis is present in the celiac disease. What is present? A severe impairment of the intraepithelial lymphocyte. IL-15 is implicated in the expression of the natural killer receptor CD94 and NKG2D, as well as an intraepithelial expression of the stress molecules, thus enhancing the cytotoxicity, cell apoptosis and villus atrophy. The most evident expression of the autoimmunity is the presence of serum antibodies to TG2. So this is the proof for autoimmunity. What is the proof? The presence of serum antibodies to this TG2. Fine. However, the mechanism leading to the autoimmunity are largely unknown, as well as their pathogenic significance. Potential celiac disease, in which the TG2 antibodies can be detected in situ without any histological abnormality, shows that the production of antibodies does not necessarily lead to intestinal damage. The finding that IgA deposits on the extracellular TG2 are not limited to the intestine but can also be found in the liver and lymph nodes and muscle indicates that the TG2 is accessible to the gut-derived autoantibodies, turning CD into a systemic disease. Fine. Now let's understand this paragraph also. We'll understand it there only. Yeah, in this page. So what is happening? After gliadin activates the T cells, we read, right? This modified gliadin is activating the T cells via these HLA-DQ2 and DQ8. These T cells release this inflammatory cytokines. Mainly, which one were the main cytokines that were released? It was interferon gamma and interleukin 21. Which cytokines? Interferon gamma and IL-21. They are mainly released, and these cytokines are causing what? I had just written here chronic inflammation and destruction of intestinal villi. That is the final thing, but they are causing remodeling of the intestinal mucosa. How is this remodeling occurring? By increase in the enzyme called as the metalloproteinases and the growth factors. As a result, the intestinal villi, they become flattened. That is causing the villus atrophy. Fine. Because of what? Two enzymes we read, right? These two enzymes, metalloproteinases and not enzyme, a growth factor. These are causing what? The intestinal, not villi, it's intestinal villi to become the flattened, and because of now as the intestinal villi has become flattened, the villus atrophy has occurred and flat mucosa, so it's causing decreased surface area. There is decreased surface area for absorption, finally leading to this malabsorption. Okay. Now this interleukin 15, no? Also we read, right, interleukin 15 here, which was immune system was activated and it was releasing this interleukin 15, which was acting on the intraepithelial lymphocytes. It was stimulating the intraepithelial lymphocytes, right? So this interleukin 15 also disturbs the normal balance of intraepithelial lymphocytes by stimulating it. These intraepithelial lymphocytes become overactive and kill the intestinal epithelial cells, right? These intestinal epithelial cells were being killed, okay, by inducing what? Apoptosis. because of this stimulated intraepithelial cells, and this further worsens the villus atrophy. So this is now again contributing to this villus atrophy thing. Okay. The autoimmune aspect of the celiac disease is shown by the production of the antibodies against that tissue transglutaminase that we read right here. So there is antibodies against this tissue transglutaminase. Okay, and this is showing the antibodies are present. That means the autoimmune is acting, especially the IgA against the anti-tissue transglutaminase antibodies, and these antibodies are excellent marker for the diagnosis, although they are not the main cause of the intestinal damage. Okay. But so what's the main mechanism of intestinal damage? It is T cell mediated immune response. Right, that is happening. T cell mediated, because this helper T cells was activating the T cells which was releasing cytokines and all. So main mechanism of this main mechanism is this activated T cells. Fine, activation of T cells, not the antibodies. So it was not very easy, but I hope you guys understood. What we just read was gluten ingestion from the wheat and barley and rye, and this gluten was broken down into gliadin, and this gliadin resists digestion, so it crosses the intestinal mucosa, and then it activates this gliadin is modified. This gliadin is modified by this tissue transglutaminase. Fine, and then it is presented by this HLA-DQ2 and HLA-DQ8 to what? T4 cells, CD4 T cells, and CD4 T cells was doing what? It was activating interleukin 15. Let's write interleukin 15 also here. Interleukin 15, interferon gamma, and interleukin 21 was released, and this all was activation leading to activation of this intraepithelial lymphocytes, right? Intraepithelial lymphocytes was causing what? Damage to the intestinal epithelial cells by apoptosis, and this was if epithelial cells are damaged, no, then it is leading to the villus atrophy and crypt hyperplasia, and this all is finally leading to what? Malabsorption. Okay. Also, B cells produce antibodies against this tissue transglutaminase. Fine. So this is all just we read. Moving ahead with the clinical presentation and associated disorders. The clinical features of the celiac disease vary considerably. Intestinal symptoms are more common in the children whose disease is diagnosed within the first 2 years of their life. There is failure to thrive, chronic diarrhea, vomiting, abdominal distension, muscle wasting, anorexia, and irritability are present in most cases. What is happening? And who mainly shows symptoms? Intestinal symptoms are present in firstly in children, and in those children whose disease is diagnosed within the first 2 years of their life. What are the symptoms present? Failure to thrive, chronic diarrhea, vomiting, there is abdominal distension, there is muscle wasting, there is anorexia, irritability. These things are present in most cases. Occasionally there is also constipation, with cases presenting with the intussusception. As at the age at presentation of the disease shifts to later in the childhood, and with the more extensive use of serological screening tests, extraintestinal manifestation without any accompanying digestive system have increasingly become recognized. So there are many extraintestinal manifestations also affecting what? Affecting almost all the organs. One of the most common extraintestinal manifestation of the celiac disease is iron deficiency anemia. This is a very important thing to remember, that iron deficiency anemia is one of the most common extraintestinal manifestation is iron deficiency anemia, which is usually unresponsive to iron therapy. Okay. This is a very important line. If you have a child in your OPD who is having iron deficiency anemia and you prescribed iron, but later on you see that the hemoglobin is not rising or even falling, then you have to think of certain DDs in your mind, and one of the DDs should be celiac disease, because it causes, its most common extraintestinal manifestation of celiac disease is this iron deficiency anemia, which is usually unresponsive to the iron therapy. Fine. Osteoporosis may also be present. In contrast to the adults, it can be reversed by the gluten-free diet in children. Fine. So this osteoporosis, it can be reversed in children. So first we saw is the iron deficiency. Second we saw is what? Osteoporosis. With restoration of the normal peak bone densitometric values. Other extraintestinal manifestations include the short stature, delayed puberty, arthritis, arthralgia, epilepsy with the bilateral occipital calcifications, peripheral neuropathies, isolated hypertransaminasemia, dental enamel hypoplasia, aphthous stomatitis. These mechanisms responsible for the severity and variety of the clinical presentation remain obscure. Nutritional deficiencies or abnormal immune responses have been suggested. Silent celiac disease is recognized mainly in the asymptomatic first degree relatives of the celiac disease and in subjects affected by the disease associated with the celiac disease. Small bowel biopsy in a silent or subclinical celiac disease reveals severe mucosal damage consistent with the celiac disease. Potential celiac disease is defined when the patient have positive celiac disease specific antibodies but without documented small bowel damage. Some disease, many with an autoimmune pathogenesis, are found with a higher than normal incidence of the celiac disease. Among these are the type 1 DM, autoimmune thyroid disease, Addison's disease, Sjogren's syndrome, rheumatoid arthritis, autoimmune cholangitis, autoimmune hepatitis, primary biliary cholangitis, and juvenile idiopathic arthritis. So these are all the autoimmune pathogenesis, autoimmune diseases which are associated with celiac disease. Such associations have been interpreted as the consequence of sharing identical HLA haplotypes, but direct role of gluten in promoting the autoimmunity cannot be excluded. There is a very big role of gluten. The relation between the celiac disease and the other autoimmune disease is poorly defined. Fine. Once those diseases are established, they are not influenced by the gluten-free diet. Other associated conditions include the severe selective IgA deficiency, Down, Turner, and Williams syndrome. Let's read this table. These are all the extraintestinal manifestations of the celiac disease. First, we are going to read about the cutaneous manifestations, and cutaneous manifestations include what? Ecchymosis, edema, dermatitis herpetiformis, follicular hyperkeratosis, and dermatitis. So, because the other side that is written is the probable cause. So, this ecchymosis and petechiae, it is occurring because of the vitamin K deficiency, rarely thrombocytopenia. Edema is occurring because of hypoproteinemia. Dermatitis herpetiformis because of the epidermal this tissue transglutaminase autoimmunity. Follicular hyperkeratosis or dermatitis because of the vitamin A malabsorption and vitamin B complex malabsorption. Now the endocrinologic symptoms, these are amenorrhea, infertility, impotence, delayed puberty, short stature, type 1 diabetes, thyroiditis, Addison's disease, and Graves' disease. Why is it occurring? Because of malnutrition, hypothalamic pituitary dysfunction, and immune dysfunction. Also, there can be secondary hyperparathyroidism, calcium or the vitamin D malabsorption with hypocalcemia. There can be hematologic manifestations like anemia, hemorrhage, thrombocytosis, Howell-Jolly bodies, pancytopenia, thrombosis, and malignancies. So this anemia is occurring because of the iron, folate, vitamin B12 or the pyridoxine deficiency. Hemorrhage is occurring because of the vitamin K rarely thrombocytopenia due to the folate deficiency, thrombocytosis or the Howell jelly bodies because of the hyposplenism, splenic atrophy, or autoantibodies, pancytopenia because of vitamin B12 deficiency and immune mediated, thrombosis because of the venous and the arterial, including the portal vein, malignancies, enteropathy, type T cell lymphoma, B cell gut lymphoma, adenocarcinoma of the small intestine. Fine, and there can be hepatic manifestations also. Elevated liver biochemical test levels, because of the lymphocytic celiac hepatitis or non-alcoholic fatty liver disease. There can be autoimmune hepatitis associated with the autoimmune hepatitis. There can be muscular manifestations also, like the atrophy because of the malnutrition due to malabsorption. There can be tetany because of the calcium, vitamin D, or the magnesium malabsorption. There can be weakness due to the generalized muscle atrophy, hypokalemia. There can be neurologic, like the peripheral neuropathy, deficiencies of the vitamin B12 and thiamine, and immune-based neurologic dysfunction. There can be ataxia, that is cerebellar or the posterior column damage. There can be demyelinating central nervous system lesions, immune-based neurologic dysfunction. There can be seizures which are difficult to treat. Unknown associated occipital calcifications can be seen. There can be skeletal manifestations like osteopenia, osteomalacia, and osteoporosis, malabsorption of the calcium and the vitamin D, secondary hyperparathyroidism, chronic inflammation, osteoarthropathy, unknown cause, pathologic fractures, and pathologic fractures like osteopenia and osteoporosis. Others can be enamel hypoplasia, due to this again vitamin D and calcium malabsorption, anxiety, schizophrenia, unknown, pulmonary hemosiderosis, unknown, aphthous stomatitis, and benign inflammatory mass granulomatous self-resolving process with the treatment. There is a National Institute for Health and Care Excellence guideline that on the indication that should prompt the testing for celiac disease. That when should we do celiac disease testing? So celiac disease testing is recommended in persistent unexplained abdominal or gastrointestinal symptoms, faltering growth, prolonged fatigue, unexpected weight loss, severe or persistent mouth ulcers, unexplained iron or vitamin B12 or folate deficiency, type 1 diabetes mellitus, autoimmune thyroid disease, irritable bowel syndrome, first degree relative of people with the celiac disease, and dermatitis herpetiformis. Celiac testing should also be considered in any metabolic bone disorders like the reduced bone mineral density or osteomalacia, unexplained neurologic symptoms, particularly the peripheral neuropathy or ataxia, unexplained subfertility or recurrent miscarriage, persistent increased concentration of the liver enzymes with the unknown cause, dental enamel defects, Down syndrome, Turner syndrome, Williams syndrome, and selective IgA deficiency. There is a clinical spectrum of the celiac disease. There are symptomatic, there is the frank malabsorption symptoms are present and signs like the chronic diarrhea, failure to thrive, or weight loss. All these symptoms will be present, right? Diarrhea, failure to thrive, and weight loss. Also there will be extraintestinal symptoms and signs like the anemia, fatigue, hypertransaminemia, neurologic disorders, short stature, dental enamel defects, arthralgia, aphthous stomatitis. Fine, these were the symptomatic one in the clinical spectrum. There is also a silent presentation in which there are no apparent symptoms in spite of the histologic evidence of villus atrophy. There is a histologic evidence of villus atrophy also present, but there are no apparent symptoms. In most cases identified by the serologic screening in at-risk groups. And there is a latent manifestation also in which subjects who have normal intestinal histology but at some other time have shown the gluten dependent enteropathy. That is called as the latent. And the potential, in which the subjects with the positive celiac disease serology but without evidence of the altered intestinal histology. There is what? Positive celiac disease serology but Without evidence of this altered intestinal histology, patients may or may not have the symptoms and signs of the disease, or may not develop a gluten-dependent enteropathy later. In the next video, we will talk about the diagnosis and treatment of celiac disease. Thank you.